Welcome. My name is Dr. Amanda Falk. I use she, her pronouns. I am a partner and chief clinical officer at the Dorm, which is an IOP and PHP treatment community specifically for young adults with locations in both New York City and Washington, D.C. And I am really happy to be here today to be discussing recovery and transformation for individuals living with severe psychiatric illness. This conversation is certainly timely as we have seen a continued rise in psychosis and mania amongst young adults, and with those diagnoses, often profound isolation. For many of our clients, they say to us that the diagnosis can feel at first like a life sentence, like something that's permanent and that will define them or limit them forever. And the weight of the stigma and the shame and the misunderstanding can make it really difficult to connect with others or to make it possible to see themselves as anything beyond their illnesses. So within our community, we've certainly been trying to create a lot of programming to help counter this. We created, for instance, a psychosis and mania process group to give young adults a space to share their struggles, to connect with each other, and to begin to reclaim their sense of self. So we're super grateful today to welcome Doctors Marotta, Mann, and Dougherty from Silver Hill Hospital, who will share their groundbreaking research and firsthand stories of people who have moved from fractured psychotic states to functional, meaningful, purposeful, and fulfilling lives. Dr. Marotta is an internationally recognized expert in the treatment of severe psychiatric illness, such as bipolar disorder and schizophrenia. He is the director of the Center of the Treatment and Study of Neuropsychiatric Disorders at Silver Hill Hospital. And he is joined by Doctors Lisa Mann and Dr. Dougherty. Dr. Mann is a clinical psychologist who was educated at Harvard University, NYU, and St. Luke's Roosevelt Hospital Center, and is program director of the Center for the Treatment and Study of Neuropsychiatric Disorders at Silver Hill Hospital. And Dr. Dougherty has a private practice as a certified life coach and has previously worked as a senior research associate to Dr. Marotta at Silver Hill Hospital. She and Dr. Mann co-authored the book Lives Reimagined, Changing the Course of Psychotic Illness. So with that said, I'm going to turn the presentation over to Doctors Marotta, Mann, and Dougherty.
Thank you, Amanda. So good to be here. We're very excited to share with all of you the powerful voices that you will hear. First, I think we need to do a little bit of the proverbial housekeeping. So let me see where my clicker is. We need to screen share with you. Okay, hold on one moment. Share. Okay, is that working? So again, let's see. Did I get that?
That's down.
No, hold on a second. Okay. We want you to know that in compliance with ACCME standards for commercial, commercial support of CME, as the speakers, we do not have any relevant financial relationships to disclose in relation to this presentation. We also want you to know that our educational objectives are the following. As a result of participating in this session, you should be able to explain how stigma and shame impact identity development and self-worth, and recognize how trust strengthens therapeutic relationships with patients, how you can identify types of support that facilitate long-term recovery and functional living, and can describe the complexity of patient experiences with severe psychiatric illness and their struggle to heal. Okay. So this is a presentation, as you know, about creating identity beyond neuropsychiatric brain disease, the individual road to transformation. About 3 years ago, Katharine and I collaborated And the collaboration culminated in the book, Lives Reimagined, Changing the Course of Psychotic Illness. This book describes the evolution in the work of Rocky and the Lodge team at Silver Hill Hospital as they built a model of a different type of treatment of serious neuropsychiatric brain disease. This approach is grounded in the belief that, as Amanda said, having this kind of persistent psychotic illness is not a recipe for decline and disintegration, but rather with help, you can reshape an identity that is informed by, but not defined by your illness. The mission of this team, as it is with the current Lodge team, was to shift patients from stabilization and move them beyond to lives that were filled with agency and purpose. For reasons that we document in the book, the ability of the team to shift patients positively was unusually high, and we wanted to share what we thought were the truths about why this occurred, because our belief is that adopting some of the elements of this different approach will really decrease the revolving door of treatment for this patient population. So in order to write the book, Katharine and I interviewed many of the clinical staff at the Lodge, psychiatrists, psychologists, social workers, residential counselors, nurses, who spoke passionately and with great consistency about what they felt were the critical elements in their patients' progress and sustained success. But we also wanted to include patients and families and get their perspective. So we asked a number of the alums of the Lodge program and their parents if they would tell their lived stories, and these are shared throughout the book. We knew that they would be moving, but beyond that, every time we got a contribution, we were struck with the power of their voices. Not only were they courageous in their honesty, but they were so generous in their support of others who were going through similar struggles. And we felt like we wanted really to hear more from this perspective. We knew what the team felt were central variables to the progress and success of the patients. Did patients agree with the team? Did they agree with each other? So what were the factors that they identified as most important to their move toward a better existence and the transformation of their situation in their lives? So we, with this question in mind, went to interview a group of patients, some of them Lodge alums, some of them patients who were working with Dr. Rob Laitman, who has a similar treatment approach, to see what they believed were the central variables in their transformations from fractured psychotic states and complete dysfunction to a sense of more cohesive and empowered identity. We want to set the stage for what's going to come for the rest of the presentation by taking a step back and reviewing what the basic themes were of the approach that Rocky's Lodge team took to treatment, because we think this will give you a context and enhance an understanding of what you will hear the interviewees talking about as we go forward. So, all right. Let's start out with a slide that basically gives you information that pretty much everybody who is watching today probably knows. Roughly about 1% of our population suffer with really serious psychiatric disorders. This is a situation which is really difficult in the context of broken mental health system. Essentially, we have a situation where for many young people with persistent illness, you have symptoms that are bring them to a hospital. They are quickly and often superficially stabilized. There is poor continuity of care. They fall through the cracks. Their exhausted families are trying to pick up the pieces as they decompensate, and then it happens again, the revolving door of treatment. We actually quote in the book comment by Dr. Insel, the former director of NIMH, who pretty much states, we were funding all of this interesting scientific research into what psychiatric mental illness is about, and yet it really wasn't touching the actual people who are struggling with the disease. So we're in a situation which is pretty much a crisis for millions of people. Before we go any farther, we want to talk a little bit about terminology, because Katharine and I made a decision as we were writing the book that terminology really makes a difference, because of the reality is that language brings with it associations. And we were repeatedly talking about the biological substrate of these illnesses, and felt that there was a serious disconnect because the label serious mental illness did not speak to these biological underpinnings. Rather, when you think about serious mental illness, generally the associations are negative. You think of stigma, you think of shame, you think of all the things having to do with a hopeless diagnosis. And beyond that, the issue of these illnesses being biologically based and having a label that speaks to that is important, because they really demand and need parity with other chronic medical illnesses. We live in a world where we know that stage 1 cancer is more treatable than stage 4 cancer, that a course of treatment for cancer, diabetes, cardiac disease can take a long period of time. Why is it that treatment for these neuropsychiatric brain diseases is limited by insurance to short stays? Why is it that when we look to intervene psychopharmacologically with a persistent psychotic illness, that somebody has to fail 3 courses of typical antipsychotic medicines before they're given the medicine which works the best, clozapine? So there are a lot of issues that have to do with parity. And so you will hear us talk throughout this presentation, throughout the book, about neuropsychiatric brain disease, or NBD, in place of serious mental illness.
And I just want to say that, part of that, for all the reasons that Lisa is saying as well, it's also how an individual can process what's happening to them and the family and the community. Because when we take it away from a sense of free will and something that actually is under the control of the individual, and we actually bring it to its biological base, we change the conversation, we change the framework.
It's not a moral failure.
Not a moral failure, not somebody's
or a
fault.
family failure.
Not somebody's fault, right? So basically, I wanted to just mention that in the book, we describe the various different aspects of this treatment approach. And we use the Lodge program at Silver Hill Hospital as the illustration. It's where the approach was developed. But we do so with a real understanding that the majority of people will not be able to access a program like the Lodge. So in the book, the way we tried to handle this was that at the end of each of the chapters that deal with different aspects of this approach, we've created and pulled key elements and guidelines that people can hopefully apply to their navigation and their development of care for their loved ones. We understand, as we're talking about this, that for all of us, all of the ideal factors rarely come together. And so there are obviously ways in which people have to adapt their circumstances, but we're talking about, I guess, an ideal scenario. So to begin with, you need, for people who are struggling with persistent psychotic illness, you need a safe holding environment where the work is going to take place initially. The patients at the Lodge were not at the most acute stage of their illness, but they were psychotic when they moved into the Lodge program. And so when you're working with this kind of illness, it's a long process. Extended stays in some place where people can develop trusting relationships, where medication trials can be undergone, where a variety of different kinds of interventions, multifaceted interventions can take place, is an important aspect of the experience. It may have to be in somebody's home. It ideally would be in some kind of a residential setting. Very important when we talk about this approach is the idea that there are basically three anchors to this approach to treatment. Trust and relationship are really the building blocks of this approach. Along with that, medication, hopefully sobriety, counters brain dysregulation, sustains stability. And then a multifaceted approach to interventions, help people re-engage, learn daily living skills, develop a sense of agency, and eventually develop social connection. But at the hub is relationship. At the hub of this approach was the team, a team of people who were willing to take on cases that other people deemed were hopeless. Every person coming into this program, every person that clinicians work with was approached as a puzzle. Diagnostic labels were generally left at the door. Clinicians looked at constellations of symptoms rather than a diagnostic label, and they were willing to take calculated risks to move people from a place where they were stuck to other, to shift symptom pictures to something that were more tolerable. One of the philosophies behind all of this is don't miss what's right in front of your face. And a critical piece of it, and Rocky's going to talk about it now, was that in doing this work, often assumptions were made in the years coming up to the point where a patient entered the program. And so they were looked at in a particular way, in a particular box. There was a lot of out-of-the-box thinking that occurred at the Lodge with this clinical team. And as I said, essentially, the first thing was taking a look at the biological and the underpinnings of what all of these symptom clusters were about. So,
and I just want to say, so we're talking here about connection and the relationship. And so throughout the book, we do have to focus on Dr. Marotta, Rocky, and his leadership and his art of healing, because, and I think in terms of anyone, you're looking for that. You're looking for someone that you can have that deep connection with, and that has that trust and that leadership and that collaboration with other members of a treatment team. And that's really important.
Well, before I'm struck, there were lead clinicians, and all the psychiatrists, at points there were 3 to 4 psychiatrists on the team. They weren't residents. They weren't, they all had 10 to 20 years of experience, which early on in Silver Hill, you couldn't even be on the staff unless you had 10 years after residency, And the philosophy was not to miss something. And so that group and the people with us was trained to always think carefully about what you might not have noticed, or what was being shown to you almost as a tease, and you don't get stuck in the textbook. Think about all the possibilities. And so that came, I think, from being trained at Cornell, at Payne Whitney. And that was a very long time ago, but when those things are beaten into you, they stay with you. So I just want to say it's not about me, it's about a history of training going back for generations. And Time Jesum is to be fearful that, Jesus, that the truth is in front of you and you don't even see it. And my experience has been, it happens over and over again. Even yesterday, it happened yet again. And that's just the way it is. But I'll keep quiet because...
No, not at all. I just want to add that one of the reasons that working in a team is really at the core of this kind of approach is because the work is long and it's hard, but it involves sustaining engagement and sustaining connection with your patients. And while Rocky is somebody who, for example, will take a telephone call at all hours of the day and night, the majority of us are not able to do that all the time. And when you have a team that works collaboratively and has developed relationships as a team and individual members of the team with patients, that kind of sustained connection can be basically shared. And that's, I think, very important in terms of work once somebody is post-discharge too, is the development of a team allows the sustaining of connection in a way that isn't always possible if you are working by yourself.
And it goes back, a keep of the Italian. The Italians talked about themselves in French, so that it's a team working together, and the morale of the team allows them to interact with and increase the morale of the patients and the families. So it self-generates energy that is for the good of all. Right? It's for the good of all, not just...
Yeah.
Okay, so Rocky, can you talk a little bit about the initial evaluation of patients? Because this is...
Well, I think what's changed over the generations is that the evaluation of patients has gotten sloppier and sloppier because it's being dictated by algorithms and by insurance companies. And because of that, it's considered, an unnecessary expense to really think carefully and give it enough time. So one of the good things for us, of course, is that we see people who failed multiple treatments, and all the previous failures, that's an enormous amount of information, right? And then we fight very hard to get permission to get EEGs, get our MRIs, to look for inflammatory diseases, to look for infections, to really make sure we're not missing something. Which is not to say we don't believe in that schizophrenia exists, but we want to make sure that we're not missing something. I mean, just last night, we found a temporal lobe epilepsy in a patient who was diagnosed as being a histrionic borderline for 10 years. But we did 4 EEGs to find it. Okay? Because we knew something was wrong. And so at my age, I'm allowed to get my way, which is good. But I think other clinicians have to be willing to fight for it too. So in the old system, the focus was on a biopsychosocial model, so there was biological, medical, brain influences, but there were also the social life, the family life, and the life of the community, and the politics. Everything seemed to be critical. Maybe that's because I'm a child of the 70s, and I was at Berkeley in the summer of love. But it's just the way we just took that for granted. Okay. And I think those of us in the team who are older brought that mindset with us, and that we're searching to find ways to get people better, to salvage as many patients as possible. So we think like neuropsychiatrists or neurologists and neuropharmacologists, as well as agents of change. Okay, so this is just the mnemonic kinds of, but this is our way of thinking. And over a 20-year period, it drove us to not pay attention to the pharmaceutical companies as much, and to rediscover that medicines from the past were often more effective. So this is like one of the things we use for many patients. We use clozapine, which is considered a dangerous and hard drug to use. But the data from the 1970s and 60s says it's the best, and all the data today is. So in Europe, it's a first-line drug, and in the United States, it's the fourth or a fifth-line drug. And it's not expensive. It's the cheapest, which tells you something interesting. And then we use medicines like that, and we mix other tricks that we've developed over a period of time. It's hard to do, the kind of research that journals want. We can't do large studies to compare one thing to another because of the illness and the complexity of treatment. But we take treatment failures and try to get them better. Not all our patients are on clozapine by a long shot, but many of them are, and that has been a good an option for many of them. It's quite remarkable. I mean, I wasn't raised to believe in these things, and it's just a matter of experience. But again, to get a young woman or a young man who was in hospital in and out of hospital for 5 years to be able to get through college, to get a graduate degree, you may use 4 or 5 medicines. You may commit the sin of polypharmacy, but it's what works. And so we focus on what works, not on diagnoses and not on guidelines published in books.
And again, I think it's important to say that the aim of treatment is not just symptom stabilization, right? It is the development of a sense of agency and social connection to the world around you. So, for example, clozapine is probably the best antipsychotic in terms of dealing with some of the negative symptoms of psychotic illness, but there are residual social issues and interconnection issues that still need to be addressed once symptoms are stabilized. And so this team has
and so it's not about a rating scale, getting a patient getting better on a rating scale. It's about a patient having a happier life, a meaningful life. And clozapine is also good because it decreases suicide rates. It decreases impulsiveness. People on clozapine maintain sobriety. We've talked about that at other lectures. And they live much longer. They live on average 10 years longer than other patients. So, I mean, there's a lot of good reasons to use it.
So, so, I mean, you're talking about oxytocin.
And oxytocin added to it is, and clozapine are both. It's an excellent mix in our hands, but that does, but I think I want to get to the patients.
Okay. All right. We will. Understandably. One of the things that we just want to say, and we'll go through this very, very quickly, is that we're doing this presentation. People talk about all of the ways in which patients actually can transform their lives who are struggling with these illnesses, but we have to acknowledge that a significant number of patients with psychotic illnesses have some kind of denial of illness as a piece of their symptom picture. And what is important in the context of this presentation is to understand that in order to accept treatment, you do not have to accept a diagnostic picture, right? You do not have to say, I understand that I have schizophrenia or that I have some kind of an illness. And so we devote an entire chapter to this in the book, but basically there are a number of different kinds of denial of illness. Anosognosia, which is really a biological symptom, neurological symptom of the deficit, and not about in any way a defensive reaction to the loss of potential. There is also, however, the added defensive denial, which can occur on an individual or a family level, which is a defense against the sense of damage. And there are multiple ways to handle this, but basically the bottom line is that in order to have a collaborative experience with a patient, you do not have to label the things that they're struggling with. You have to enter into a relationship where you listen and try to understand what bothers them. And then on a symptom by symptom basis, you can address this. What is also important to understand that successful transformation is a long step-by-step process. It doesn't happen overnight. And it really, you will hear our interviewees talk about the process, which is long and hard, but it involves small steps begetting more small steps, begetting more, and something that Rocky often talks about is the virtuous cycles of recovery, which is that one small change actually can have a ripple effect and then trigger another small change, and that this process then leads eventually to an ability to move out into the world. I think I'm going to try to move us along.
And so there we, one of the things we'd like to really focus on that we saw in this approach is bringing the family in, because families come in with their loved ones exhausted, feeling isolated, and with such a burden of the illness on the whole family and on their loved one. And so through this approach, giving families tools to understand what's going on and making them partners in the treatment team is something that has been essential, because they will be the continuity for their loved one after the program as well. And so, we focus on families as the allies. And then there's, the peer support models. For example, the clubhouse model, there's 350 clubhouses in 32 countries. And that's, where people are able to go to a place where they belong to this clubhouse, and they work together, and they, see others recover. Yeah. And so there's like peer modeling. And Team Daniel is another wonderful peer support where families get together with their loved ones for social support. And then there's education and resources. So both families and, peers are very important as we move along. Okay. Want to speak to this?
I think this is really critical right now, is that to recognize that there are vulnerable periods in a person's life, in the young people, and some of the things you've already heard that and all those stories, right? Exposure to alcohol, stimulants, and marijuana. 80% of the patients that came to us who were severely ill had a history of both marijuana use, not an occasional use, but real use and exposure to stimulants. And the data coming out of Europe and Canada on rising rates of schizophrenia shows seemingly clearly now that the rates of schizophrenia are rising by about 25%. Yeah, what does that mean? If you have an illness with a near 1% rate, you raise that by another, 0.25%. That means in a country like the United States, another 100,000 plus cases of a degenerative brain disease. This is very dangerous. So we have a responsibility, I think, to help people understand this. And we're not going to go back to outlawing cannabis and alcohol, but doing something about exposure of 13 to 17-year-olds and 18-year-olds to dangerous substances, which is the story we hear over and over again. So this is a whole nother lecture, but the nervous system is plastic, it's changeable. People can get better. You can't keep, insulting it with substances which are toxic. And there are some medications which are protective and help in recovery. And that's an incredibly interesting thing. Again, I would love to talk to people about, but there are people who are just expert in this, and that this is really important. So sobriety is an important factor in recovery over time from these illnesses.
So then as we go to look at the future and actually to what we're going to, you hear voices of our participants and how they've maintained their stability. One of the things that we really emphasize is stability, has to be guarded through continuity of care. And so discharge is never the end of treatment. And, we look at step down programs as something that, is useful. And then the enduring relationship, that's absolutely key. And you'll hear it in our interviews with the core psychiatrist and therapist and a whole team in some cases, family. That enduring relationship of trust is absolutely key and important to stability. And then we also see, as you'll see in the interviews, participating in society, re-engaging, going to school, finding a job, and finding purpose. And those are things that we see.
Love and work, to quote an old master, right?
Yeah. All right, so we're gonna now move on to really the heart of the matter. Important to understand also that resilience is not about forgetting what has happened in the past, but recognizing that maybe the plan has changed, but that there are still options and that you still have choices to be made. And you will hear people talk about this as we go forward in the presentation. They will talk about connection. They will talk about the incredible importance of having hope and the sense that somebody is in their corner and will persist. You've heard from Rocky about the biological rigor that's necessary to really understand what is triggering psychotic symptoms. And of course, for everyone, because the work is hard, hope is essential. So here we go. We are going to introduce you to the young people who have given these interviews, and we're going to talk essentially about various different themes. But before we do this, it seemed important to at least define what we meant by the terms. So what do we mean by identity? Well, identity to us is multi-layered. There's obviously the genetics, there's temperament, there is history, but it involves, on top of that, memories that become the framework of an internal narrative, internalized feedback, internalized models, and the development of aspiration, goals, fears, hopes, and dreams. How is identity formation disrupted by psychotic illness? Well, we have to really think about that too. Experiences are disjointed and contradictory as you have fractured experiences. If you are suffering with voices give problematic feedback. You're hearing in your head things that are disrupting your experience and your sense of self. There can be difficulty processing information. There probably is difficulty processing. Lack of social connection interferes with internalizing models. Fractured experience interferes with developing self-confidence, goals, dreams, and aspirations. So what do we mean by transformation? Well, we think of it as both an objective and subjective experience, right? What you see in terms of somebody's progress and also what they experience as progress or as movement. Identities informed by, but not defined by illness. So the development of an identity, a sense of identity outside of your illness. It involves increasing functionality, a sense of agency, a sense of purpose, connection to the world. And in order to have transformation, you need to have intellectual capacity, aspirations, ability to sustain concentration, and the ability to respond adaptively to stress. All these things have to be aligned, which means pretty much that transformation looks different for every single individual. It is not one particular idea of success or achievement. It is, again, very different for each individual person. So you want to talk about our sample?
Okay, so we had 8 people, two women and 6 men between 25 and 35, and came from all from high socioeconomic backgrounds. They participated and consented to be audio taped and agreed to be part of today's class. And where desired, we do have someone, in some cases they asked for their voices to be read by someone else. So while the transcript of the exact words are there. 6 of the interviews are sober, and 2 drink alcohol socially. And all of the interviews are currently taking clozapine. Most are taking additional medications, and 5 also take oxytocin. 7 of them fully acknowledge their illness and the importance of medication to their stability.
All 8 of them were severely ill in the past. And I say this because you listen to them and they're so articulate. And so it's really important to recognize that they all struggled with some or all of the following symptoms: severe OCD, auditory visual hallucinations, depression, inner turmoil, extreme social anxiety, over-sexualized behavior, flat affect. 5 of our interviewees described cannabis and/or LSD as the possible trigger for their severe illness. Some of our interviewees described current breakthrough symptoms such as voices, significant OCD, depression, and social anxiety. And that's important also, I think, to remember, is that our interviewees are not symptom-free, all of them. Supportive relationships: 2 of our interviewees work with Dr. Laitman, 5 work with Dr. Marotta, and 1 with a psychiatrist previously connected to the Lodge program. 4 have close relationships with therapists in addition to their psychiatrists. All of them have strong family support. And this is written when the interviews were done. 1 had a partner when the interview was when the interview occurred. That partnership is no longer, but all have some close friends and speak positively about the importance of community. All are currently working and/or are in school with differing degrees of specific future plans. Most expressed a desire to give back to others who are struggling. The themes you're going to hear as we listen to the voices: shame, isolation, discomfort, importance of relationship and support systems, treatment, various different aspects, framing illness, achieving stability, gaining perspective, some of the challenges that they faced and face, finding a path, and finally, changing the narrative. Let's start with shame and isolation and discomfort. So when we did these interviews, we were obviously trying to get to a better understanding of our interviewees' subjective experiences, with ultimately the aim that we could work with more sensitivity and more effectiveness. I think most of us know that shame is a big part of the clinical picture of various different clients that we work with. And we, as we saw, and we know, it involves negative self-evaluation, increasing anxiety and ability to act, increasing withdrawal, isolation, and loneliness. But I think one of the things that came out of these interviews was a stronger sense of the interference that the role it plays in interfering with communication of internal experiences, which I think is really a critical issue as clinicians to understand, that for a number of our interviewees, it was anywhere from months to years before they actually communicated to their doctors or to a therapist what was actually going on in their head. And so the understanding of that and the sensitivity and the attempt to really try to understand more about that, I think is...
Yeah, being unworthy of being helped often was part of it too.
Right. And again, if you feel that somebody doesn't like you, that of course will exacerbate paranoia and withdrawal. So all of these things are critically important and related to shame. What are the key support elements that our sample found helpful? Well, to begin with regards to the people who work with them, having access to their therapist and feeling that they would respond quickly. And we've talked a little bit about the importance of teams in this regard. But I think the truth is that all the people we spoke to felt that having a responsive therapist or a responsive doctor was incredibly important to their ability to sustain connection, particularly when they were struggling. Feeling respected and that their individual story was important. Again, this is a really critical issue, I think, because all of our interviewees talked about feeling that they were being seen for more than just their symptom picture, feeling that their therapist had expertise and resourcefulness. People who have persistent psychotic illness have been through just incredible months, years of struggle. And so to have a collaboration with somebody who you feel has not only information that will help you, but the persistence and the hope that they can give to you that maybe the puzzle will be solved is an incredibly important thing. Experiencing a less traditional doctor-patient relationship. He treated me as if he was family. Of course, a lot of us have been trained in a traditional approach, but I think particularly with this population, the idea of experiencing a sense of connection that goes beyond that doctor-patient sort of structure or boundary is really helpful to generating trust and then the beginning of a sense of what connection can be like. Feeling that their providers communicated hope. A lot of these people feel helpless, as do the families. With regards to family support, the sharing of normal experiences. This is really like a small but important thing, that for so many of these patients, they have been the outlier in their family dynamics. And so just the ability to sit and watch a football game or go running with your dad is an important thing. And being helped by your family to connect with peers and explore different experiences that, again, as one of our participants said, it's more than just going to doctor's appointments. It's actually having somebody who continues to try to expose you to something that might just click and work. And then feeling, of course, non-judgmental acceptance by the people with whom you're working, with people, with your family. Why are sustained relationships important for this population? Well, psychotic illness, of course, makes the development of trust and connection more difficult because you've had a fractured internal experience. And so having a sustained relationship and maintaining a relationship is particularly important. Clinicians and teams who know their patients well are holders of historic memory and can remind them about past consequences, experiences, identity beyond illness. Clinicians and teams who are trusted can provide a sense of safety and anchor during periods of disruption. And obviously their communications of hope are more likely to be believed if you sense in them an ally and somebody who's sort of been by your side. Having a partner in the struggle counters feelings of patient loneliness. This is a big issue for our group. A sense of loneliness and isolation. And having a partner in the struggle counters a sense of being coerced, which is particularly important if somebody is struggling to accept that they are ill at all. Clinicians and teams who sustain relationships are more likely, again, to be experienced as allies rather than enemies. Let's hear about our group's sense of the treatment process. So, some reminders. Be attuned to how your patient frames their struggle. One of our interviewees says, I felt burnt out. That was his experience of his struggle, and dysfunction, in order to be addressed, doesn't need a diagnosis. Take time to get to know your patient. Listening and being responsive to their experience was clearly meaningful to our participants and respectful of their sense of self and autonomy. Helping to articulate disorganized thoughts was also extremely comforting to people who couldn't quite get out what they were feeling. Allowing both humor and compassion into the session. I know Katharine and I will both attest to the fact that we hear Rocky laughing with his patients all the time. Supporting parents helps build a bridge back to a patient's sense of connection to their family. And that is one of the core tenets of the approach, is that trying to help people build that bridge back to family and community. And peer modeling is important and can give perspective, right? It's good to see somebody else's perspective, and also, excuse the typo, you could see a reflection of yourself sometimes when you see that behavior in somebody else. Being in a peer situation also reduces a sense of isolation, which is critically important. Very quickly, so that we can have plenty of time for discussion. These interviewees were incredibly articulate about the perspective that they had gained. Not everybody that we work with is that able to articulate these thoughts, but hearing them, gives us a chance to actually introduce it to people that we work with who haven't yet articulated it. Just do the next thing, work your brain, be open to everything, even the negative. Respect life, realize you are not alone. Learn to develop a good relationship with yourself. It takes time to get to know yourself and who you are. Understand what is important to you: social relationships, family, romance, professional life. Well, so quickly, challenges. Losing social competence, that's huge. Learning to live with symptoms. Thinking all your symptoms are in the past. Seeing yourself beyond diagnosis, and losing hope. Finding a path forward. Well, our interviewees talked about experimenting with different therapeutic tools and modalities to address different types of symptoms, trying different kinds of medications to address different symptoms, for example, oxytocin to address social anxiety, getting accommodations if necessary, small but not unimportant, finding small groups which feel safe to practice social engagement, going to AA, peer support groups, small classes, going to a clubhouse, and staying connected with your treatment team. All right. So, time for conversation.
We have so many questions and comments that came through. I think, hearing the voices of those directly impacted has been really powerful. That's certainly showing up a lot in the chat, and just a lot of gratitude for the courage that they have in sharing their voices and stepping forward. It's incredible and powerful. So we're all grateful to them. There's a lot of questions. I'm going to hop around and try to get to as many as I can and consolidate, because there's some that are similar. But let's start here. One attendee asked, of the 8 folks that were interviewed, how many are on clozapine?
Of the whole group of these 8,
Yeah.
All of them,
all of them,
I think.
Okay.
all of these
Yeah.
8, and maybe 70% of the 80 to 90 now through the program.
Okay. And then their follow-up question is, did you try other other antipsychotic medications before clozapine as per insurance requirements?
Yes, of course I'd say so. No, but yes, because they came to, remember, we were picking up
Yeah.
failures. So
Right.
they were coming to us and we would often try something else too, but we were picking up people who had been through often years of treatment. And this group, yes, these 8, 5 or 6 attempts before us.
Okay. Okay. You all spoke in the presentation a bunch about how to approach clients who are in denial about their illness. One of the attendees is asking about how to approach, how to work with parents who are in denial and also might have very strong feelings about medications, about clozapine, who are doing a lot of their own sort of Google research. How do you work with these parents when this comes up with the families?
An enormous amount of time. And you got to kind of get people to understand that it's in the end it's tremendous risk to not do something. I mean, we just came through that where I spent weeks trying to convince a family that we had to go to court and we had to bring somebody in. And it's just very hard, but it has to be. There's no way out. If you're going to do this work, you have to commit yourself to that. I mean, the one we just finished, she came in 3 days ago. It wasn't my patient. It was a consultation for somebody else. But it took weeks to bring it to that point. And now there's real hope. I mean, the clinical team it's just such, I mean, to think that you can help somebody that's on the edge of destruction is, I mean, it's just about the most wonderful thing that you can go through as a clinician. So you have to look at it as that's your life's work and commit to it, I think. But yeah, you have to recognize that people don't tell you the truth. I don't know how often, after 4 or 5 months, someone tells me I never admitted I had voices. The voices told me not to tell you, and so you have to learn how to bring it out. Like this whole business about, I do this one, I've had this really wild experience where, a patient eventually tells me that there's a voice that tells them not to tell me there's a voice. I mean, can you believe something like that? And then there's a pause and they said, well, actually, and then you get into the system with them and they, and then sometimes you can break their denial and then you can tell the family, when you can tell the family just how bad it really is, then you can move, all the pieces. The hardest piece to move is usually the insurance companies these days, Yeah.
I just want to add that, families in denial are still generally suffering. There's an experience of suffering. And so the sense of trying to connect with somebody around the experience of suffering without necessarily challenging their frame at the moment is the beginning of a collaboration. And as Rocky said, that often takes little step by little step, over a longer period of time, and he rarely gives up. So.
And also, I would also just say with families, I think, to go back to earlier themes of shame and stigma, I think it's so important to reframe. I think with families, it really helps to try to have them have a deeper understanding of that this is a brain illness. And to the extent that they start to be able to relate to that and actually to talk to people, for families, peers are also good. So talking to other families who have been through this or to someone who can help them feel that they are heard and that they actually deeply understand their experience. So, building that trust with families as a practitioner, in this kind of work, that might be a therapist, I'm a coach, it's all different pieces that come together to build that trust so that the family can then move towards accepting something that's so deeply hard to accept.
Yeah. No, the families undoubtedly need that same type of peer support as the client, and connection, and hope, and all of that. Another related question, kind of, and we certainly hear this from our families from time to time, is what are your thoughts on you know tapering off medications once somebody has become stable and is doing well?
I believe in it, we do it.
Mhm.
I mean, I always tell stories of a patient that we shared almost 20 years ago who was on 5 medicines, including, I think, 700 of clozapine, and he's now on only clozapine, but he takes 6 1/4 milligrams. And he's a professional who is in our field at the very highest level.
Mhm.
But if he doesn't take the 6 1/4 milligrams, he will have an episode.
Right.
And there's no measurable blood level. There's no reason to follow the rules about things because there's nothing in him. But I think of him as being, it's like one of those things you meet. I have a number of people who are on 25 milligrams who at one point were on 600 or 700. So we bring them down. But there's also tragic stories of people coming off.
Right.
And a lot of them, in my experience, if you make that mistake or get missed, the hospital as a whole, we haven't published them, but there's people, when they see somebody looking good, they think, well, maybe all they have is OCD, or all they have is, anxiety disorder, or they're really just a borderline personality. And then they take them off the medicine, and then 3 months later, it's a terrible situation.
And I mean, to add to that, I think the piece of that you're speaking to is that it's a collaborative effort. Usually it doesn't work so well if a patient on their own just decides precipitously, okay, I'm going to go off my meds. So most of the success stories that you're talking about have been a collaboration where a patient says, do you think we
over
could,
months,
right,
many
could
months to
work
years.
on this? And then it is a
Right.
titrated experience.
Yeah.
But
I've often found that, like, a lot of times that question gets asked by parents at the beginning of treatment, before the medication has even reached a therapeutic dose, before there's even symptom relief. So, my response is, first things first, let's first help them to feel better, and then we can worry about all that other stuff at a later time.
But just to this point, a theme in the book is also to, we talked about recovery. That word is used, but we shy away from it a little bit, because if we're talking about a brain illness, then there's a piece of this journey that's important to accept and embrace, that maybe you're going to have something and that you're going to need that treatment long term.
Right.
So, it's a piece of that.
Yeah, absolutely.
This is a big one, and I know that we've done other presentations on this topic, but it has come up a couple of times in questions, so I do want to ask it. Can you all speak a little bit as to why drugs like cannabis and LSD may trigger symptoms of psychosis, schizophrenia, schizoaffective disorder, etc.?
Sure. Just because the way we've evolved as biological organisms, I mean, cannabis is a very complicated plant and a number of chemicals there. Some of them are toxic. Some of them are toxic to very specific parts of the brain. And there's a variability of vulnerability because we all have enormous genetic vulnerability. So it's what we see. I mean, it's just to use a funny word, it's empirically true. We know that because there's numbers. I mean, the data out of Denmark especially is troubling. Now, there is no illness, there's no set pathophysiology, say, to schizophrenia or the number of genes involved are thousands, the variability is just enormous. And we have to try to figure out what that really implies, in terms of vulnerability. Yes, there are people it doesn't bother, and yes, there are people it does, but we do know that the brain goes through remarkable changes, around puberty, from maybe 12 years of age to 21 or 22, depending. And to expose it to substances which are toxic, various kinds of toxins, amphetamines actually cause, neuronal extensions to die back. You wouldn't want to necessarily play with something like that if you didn't have to. And cannabis does strange things to the hippocampus and other structures. So, I mean, I would say I was at Woodstock. I really was. And I was at Berkeley at the Summer of Love. And I lived in a commune. So I wasn't born with a right-wing animus. It's these things. I lived, through those. And I'd never had really bad experiences, but I saw them happen even when I was young. And so I'm not so surprised, right, with the data. So if people want to get together and go over it, we have lectures on that, the data from Canada, from Scandinavia and from other places. The potency is just different,
Yes.
right?
Yeah, hugely.
Yeah, 1 to 2% at Woodstock, and in the dispensaries are 40%, and gummies are 100%. So I don't know what it would be like to smoke 10 joints or 15 joints in a day. It's just it's you wouldn't want to have 2 bottles of scotch a day either, right?
Right. Right.
Yeah.
Can you all address comorbidity between schizophrenia and ASD, differential diagnoses, treatment when there is comorbidity?
Well, it depends on where you're trained. I mean, if you were trained in a big autism center, at an academic center, you would say that, well, 40% of people with autism spectrum disorders, right, actually will exhibit the signs of schizophrenia by, say, 21 or 22 years of age. And then, or if you were trained classically in Europe, you would say that autistic symptoms are part of the core symptoms of schizophrenia, disorders of, cognitive association, autism, ambivalence, not hallucinations in the classic German system are not the defining characteristics, right? It's a disorder of thought and association. And so they overlap, and the genetics overlap. Not that we know how complicated the genetics are, but to say that doesn't give us an answer. So there's a whole spectrum of disorders that get lumped into these things, but there also are delineations, right? So it doesn't mean that if someone has autism spectrum that they're going to be schizophrenic, right? Or that you can't have what's called schizophrenia without being particularly autistic. I mean,
Right.
And in this approach to treatment, since the focus of the approach is looking at constellations of symptoms rather than a diagnostic category, in some ways, it's not that in any way is irrelevant, but in terms of how you're approaching it, you're looking symptom by symptom. So somebody who has many of the symptoms of autism spectrum disorder is somebody who likely would be treated or placed on oxytocin, for example,
Right.
to try to counter that kind of symptomatic picture.
Right. And that leads to the last question I'm going to ask, because we have 3 minutes, but there was a couple of questions that came in about oxytocin and how it works, when it's prescribed, why it's prescribed. If you could, in 3 minutes, if you could speak to that just a little bit.
really fast.
Mhm.
We got into it because there was a literature on treating autism with oxytocin.
Mhm.
That was equivocal. When I see an equivocal thing, I often say, if buried in the data, it wasn't that it sometimes helped, it sometimes didn't. That means it could help some people in certain circumstances.
Right.
So we began trying it, but we played with it in terms of the way in which it's given. It's usually sold as a spray, a nasal spray.
Mhm.
You know, it doesn't always absorb like that. And so we had it made so it could be absorbed under the tongue so we get better blood levels. And now to do research on it because of the epidemic, we couldn't do, I want to get into it, but it became hard to do research. But what we discovered was the patients told us it helped us, helped them, right? And so one of the women speaking there that you heard,
Yep.
she was the person who convinced me it did something. We gave it to her and I asked her how she was doing. She said things were really different. She said, instead of sitting at the back of an AA meeting and not speaking, I now sit in the front and I
Mhm.
talk. And I said, I could tell something's different. I said, you can look at me.
Mm.
She says, yes, I can look at you and I can look at other people. And from that, that's why she said it, my life was changed by it. She was then able to go back and finish college. She was able to go to graduate school and she's able to be an administrator. And her family says she's also now a member of the family in a totally different way. And she's happy.
Yeah.
And because she can be at ease with people.
And I know we have to stop, but one of the things that I think should be said out loud about oxytocin is there are very few side effects. I mean, you know, we haven't really talked about side effects and people enduring that, but oxytocin, you know, empirically it works or it doesn't work. And people are not always aware of how it works, but observationally you can tell. But there really is not much downside to trying it.
Yeah, I mean the staff, if I don't tell them we put somebody on it at the houses, they'll
Mhm.
tell me something changed.
Mm. Yeah.
That they're chatting with people.
Mhm.
You know, they're going out and
Right.
hadn't done it previously.
Right.
But it's not everybody. All these things are not everybody, you know. It's
Sure. Thank you. Thank you all so much for not only for this presentation, but for the work that you do on a day-to-day basis, the impact that you have on individuals out there who are seeking out help, the field in general. Truly, thank you so much.
thank you. But
Um,
it's a very big team, you know. But
yeah.
in Monday, it's a huge group of people working together. So
Yeah, it's super impactful. So thank you. And thank you to all the attendees for coming, for engaging in the Q&A and in the chat. I'm sorry we didn't get to all the questions, but I know there will be more CE events in the future on this topic and related topics.